So, good afternoon, everyone. I will start off the lecture for today, and thank you all for coming. This is the first lecture of our Endocrine Grand Rounds Multidisciplinary Endocrine Conference for the year. And before I start, I would like to thank all the people who have been part of this last year and also who are heavily involved in arranging these and agreeing to give lectures, particularly a couple of Wintergers from pediatrics and Carrie Kling from biochemistry, who arranged for the pediatric and molecular and cellular endocrinology portions of it. So today I'm going to talk to you about Nafld, Nash, and endocrine perspective, talking about Nash to diabetes, diabetes to Nash, and more. So I have no disclosures to make. So what I'm going to do is to give you a general outline, an overview of Nash and Nafld, talk to you about diabetes and diabetes therapies, the impact of those on Nafld and Nash, endocrine disorders associated with Nafld and Nash, and the impact of their treatment of these, and also some aspects of cardiometabolic risk associated with Nafld and Nash. So this is a very broad topic, so we'll have to give you a bird's eye view of most of these things that I'll be talking to you about. So I'll first start off with a bit of a historical perspective on this. And one of the things that I liked here was to note that the first 1836 description of fatty liver was by Thomas Addison. We all know Addison for Addison's disease, but he also described fatty liver. So from the beginning, it was an endocrinologist who kind of, was interested in this. And another name which many of you might know, or maybe not, is Austin Flint. Austin Flint, we have heard as an Austin Flint murmur, if you know anywhere, you would have heard about it. But Austin Flint was also the chairman of medicine at University of Louisville from 1852 to 1856. So his name was also included there. And then there are a number of people who have over the years helped understand the evolution of this disease over time. And our modern era really started somewhere in the 1980s when the terms Nash was used by Ludwig from Mayo Clinic. And since then, we have had a lot of advances understanding the mechanisms of disease and trying to develop new treatments. So one of the interesting things is between 1850 and 1970s, there were some insights into the mechanisms of this disease. And to me, what was interesting was that this is basically what we know about the disease even now. We know some of the details of what happens, but the idea that fat is deposited in the liver, and this occurs due to delivery of fat from the adipose tissue, and in the adipose tissue, it cannot go out, or that it cannot be fully oxidized, and also that the liver can make fat. So that was the whole idea that they had about it. Of course, now we know more about mechanisms by which this might happen, and of course the role of insulin resistance, and other things. So this was how this whole idea was developed. So to give you a general idea of the problem of fatty liver, non-alcoholic fatty liver disease in the United States, there are...
The slide.
Oh, I can see it here, so I don't know. it's the projector issue. Okay. So it afflicts about 80 million people in the United States, and its progressive form, which is Nash, affects about 15 to 20 million people. Then you have another 20 to 30% over 3 years having fibrosis, stage 1 to 3, and then a further 20% of those going on to stage 3 over 2 years with cirrhosis, liver failure, which may lead to liver transplant or liver death. But the main thing that has been appreciated over the last couple of decades is the fact that among people with Nafld, cardiovascular disease is the leading cause of death, followed by cancer and liver-related death. So that's why it's important for us to understand not only the liver aspects of this disease, but the more systemic aspects of the disease. Now, this is a slide which for me is very difficult because it says that some of these are bolded in red and some are in green, and I'm red-green colorblind, so I don't know what is what. So basically, the thing about Nafld and Nash is that it is a syndrome with several different components and many risk factors, modifying factors, and outcomes. So it's a whole set of complex interactions of disorders. So the things that we know of the comorbidities: obesity, metabolic syndrome, insulin resistance, type 2 diabetes, dyslipidemia, hypertension, sleep apnea, PCOS, hypopituitarism, all these endocrine disorders. So you can see that why endocrinologists need to know more about this, and also why endocrinologists have been involved in a better understanding of the problem of Nafld. Then there are genetic factors that impact the progression and severity of this disease. And there is the microbiome, and then nutritional factors, which both positively and negatively affect the outcome of Nafld and Nash. So we have to remember this because all of these are important to develop a comprehensive plan of management. So in the last few years, there has been some controversy as to what should this be called, because having a name that is not something, which is like non-alcoholic fatty liver, means that it is not this, but something else, is not a good way of naming things. But at the same time, this has been a term that we have used for a very long time. So some of a group of gastroenterologists and endocrinologists and internists, they all got together and at the International Society changed the name from Nafld to Mafld. Mafld is metabolic dysfunction associated fatty liver disease. Now, there is a problem in trying to come to the definition of what Nafld is, and there may be a problem trying to, figure out whether that is a good thing or not. I think, as far as I know, the American Gastroenterology Association has not accepted this change in terminology. But as you can see here, there is an overlap, but there are some patients who have Nafld, that means who don't have other metabolic features. And there are some people who fall into this category who may have other factors that are causing the fatty liver. So there is some overlap and some problems in this definition also. So you can see here that the definition that has been proposed is to include in adults with hepatic steatosis, 3 groups are classified as Nafld. That means one, they have hepatic steatosis by one of the criteria for measuring it, that they're overweight or obese, and if they're lean or normal weight, they have these additional things, which is waist circumference, blood pressure, plasma triglycerides, plasma HDL, prediabetes, 2-hour glucose, insulin resistance, high CRP, and then type 2 diabetes. Basically, is actually defining metabolic syndrome in a way, So that's what has been used as the definition. But this is not something that is widely accepted, but it has been proposed and something that may evolve in the future. So, Nafld is a term that is given to the presence of hepatic steatosis, either by imaging or histology, in the absence of alcohol abuse, medications, or other causes of fatty liver disease. It's certainly the most common chronic liver disease in Western societies, with 50 to 60% of adults with obesity having steatosis. The presence of obesity, particularly when associated with type 2 diabetes, will increase the risk of developing the more severe form of this disease, which includes hepatic necrosis, lobular inflammation, and risk of cirrhosis. That is what we call Nash. And if you look at this statistics out of 664 middle-aged Americans, 38% had Nafld, and among them, more than a third had Nash. So, this is a highly prevalent problem. When you look at it in patients with diabetes, this is even more common. And we'll come to that, So patients with NASH are also at a higher risk of developing hepatocellular carcinoma. And finally, the risk of cardiovascular disease is much higher and the leading cause of death in Nafld. So when you look at patients with diabetes, they have the highest risk of having clinically significant fibrosis. So in a recent study, 561 middle-aged Americans, they found people with diabetes had the highest risk of progression to fibrosis. So not just having fatty liver, but fibrosis. So one of the things that I must mention, though, is that diabetes and hyperglycemia increases fibrosis everywhere. So whether it is in blood vessels or the heart or joints or wherever, it does cause an increase in fibrosis. And there is a whole series of mechanisms involved in why fibrosis increases with diabetes. So the prevalence of Nafld was 70%, and that of moderate to advanced fibrosis was 15% in this group of patients. And one of the other things that we have to remember is that less than a third of these patients with fibrosis had AST and ALT that were elevated. So if you're focusing only on the liver enzymes, we're going to miss this. And these are one of the things that we have to keep in mind, because as we try to identify more people at risk and trying to screen them, we have to have good tools to be able to diagnose the problem. So just using ALT or AST as the only criteria is not going to capture all the people at risk. In fact, there are studies in diabetes, and a couple of years ago we had presented our own study with people with diabetes who had elevated CK18, and these were all people with normal ALT and AST. So people with normal levels of ALT and AST can have significant amount of fatty liver disease. So it is also an expensive disease, especially for the 18 million people who have type 2 diabetes and Nafld. The cost of medical care will climb to $55.8 billion and account for about a third of all liver transplants, 812,000 liver-related deaths, and 479,000 cases of hepatocellular cancer. So the bottom line is the problem of Nafld is quite large, and the problem is made worse by having diabetes, and having the combination of diabetes and Nafld or Nash is going to actually increase the risk of poor outcomes. So these are studies that have been done that assess the incidence of diabetes among patients with Nafld. So talk to you about how diabetes will make Nafld worse, but this one is talking about how Nafld will actually increase the risk of developing diabetes. So it is a two-way problem where the presence of Nafld will increase your risk of developing diabetes, and the presence of diabetes increases your risk of developing Nafld or Nash. So you can see here that, in all of these studies, when you look at the controls versus those with Nafld, you have a higher incidence. This is incidence, not prevalence. 1.8 versus 8.1% over 4 years, 2.3 versus 8.5%, 3.7 versus 9.9%, 0.8% versus 4.3%. So across the board, what you find is that the presence of Nafld will increase the rate at which someone will develop diabetes. And of course, the other thing is true that among patients with diabetes, there is a higher prevalence of Nash or Nafld. So, most of these diagnostic metacycling in ultrasound. One of the things is that, fortunately for us, this month we'll be having 3. I don't know the 4th topic, so I don't know if that may also be related to fatty liver. Next week, we will have a gastroenterologist, Dr. Loretta Joplin, who specializes in this particular topic. Will talk to us about Nafld and Nash. And so I won't cover some of the basic liver-related issues and also the overall aspects of Nafld and Nash. I will leave it her to cover that. I will cover mainly the endocrine diabetes-related aspects of this. And then I know Barbara Clark is going to talk later this month on some of the molecular mechanisms by which, fatty liver and associated problems are there. So, and I'll show you in my last slide why that kind of goes well with what is currently happening. So, this is the general outline of the mechanisms that are there that lead to the development of fatty liver. So, what you have here is muscle insulin resistance on the one hand, and then you have adipose tissue insulin resistance, and then you have diets which with increased glucose and increased fat intake, and then of course fructose. These leading to if there is insulin resistance, you will have more of higher amounts of insulin in the liver, which also drives de novo lipogenesis. Same thing with high fructose intake. Then you have fat coming in from the peripheral tissues, increased chylomicron remnants from dietary fat, these coming in from the adipose tissue, and then all of these leading to an intrahepatic accumulation of triglycerides. So that is the mechanism that is generally applicable to all of the metabolic related fatty liver disease, particularly those related to the metabolic syndrome and its components. So one of the things, again, as I said, it's a very broad topic. It's difficult to cover all aspects of it. The elephant in the room, which I will not talk to you much about, is obesity. So there is an underlying problem of obesity in most of these situations, but it doesn't have to be. Lean people can develop Nafld and Nash. But that is a very important thing that we need to address, so that we have to keep in mind. Now, when we look at the natural history of type 2 diabetes, and then look at what happens in Nafld, there are some overlapping features. I mean, if people have looked at the type 2 diabetes progression, they would have seen a similar picture. The only thing here, the bottom here, would have been slightly different. But I'll go through this to explain as to what happens over time, which we think is what is leading to this dual problem of dyslipidemia, hyperglycemia, fatty liver, and of course associated metabolic abnormalities. So the first thing that you're having is a development, and this is a normal glucose tolerance, normal fat. This is normal. So as the insulin sensitivity decreases, there's an increase in insulin secretion. Blood sugars start rising, but it is still in the normal range. So this is where you have a non-diabetic person, and the person could still be lean or obese. And you will see some of the early signs of NASH or NAFLD. Then as the disease progresses, you will have more of insulin resistance. This is insulin sensitivity. So as the insulin resistance increases, there is a higher level of beta cell function. But then that is when you get dysfunction. So not all people who develop NASH or NAFLD will become diabetic. So if you're able to make enough insulin, you will still have NAFLD or NASH, but you may not have hyperglycemia. So when there is beta cell dysfunction leading to beta cell failure, then it progresses to diabetes. So that's when you get the development of type 2 diabetes and progression of type 2 diabetes. So in this whole process, you're going to see that the fatty liver comes earlier than what you see with respect to a disorder of hyperglycemia. So this combination of progressive worsening of insulin sensitivity and then a decline in beta cell function will lead to the progression to diabetes. So, and this is in turn caused by the fact that insulin resistance now will cause an excess of substrate transported to the liver. So that is where a lot of the problems will start, which in turn leads to two other problems, which is glucotoxicity and lipotoxicity. So as there is an increase in free fatty acid delivery from the adipose tissue, and also from the muscle, you have lactate and amino acids coming in, and having more glucose. Then you progress to development of diabetes. So what we have is that NASH will forms the underlying thing leading to diabetes. At the same time, one of the important things that we have focused on probably in the last 20 years or so is to look at adipose tissue insulin resistance. When insulin resistance was initially described and measured, all the attention was on blood glucose, and glucose disposal is mostly in the muscle. So whenever studies were done, the glucose disposal rates that were calculated were all related to muscle-related glucose disposal. However, with newer methods looking at fatty acid transport, and we are able to look at the sensitivity at the level of the adipose tissue. And then what we find is that in obese individuals, and particularly in individuals who have NAFLD and progress to diabetes, you have adipose tissue insulin resistance, which increases lipolysis and increased free fatty acids being delivered to the liver, which in turn causes lipotoxicity. There are also a decrease in anti-inflammatory adipokines, adiponectin, which then causes insulin resistance in the liver. There's an increase in pro-inflammatory cytokines from the adipose tissue, and also a number of these factors in turn will cause insulin resistance at the level of the liver. So there's a combination of adipose tissue insulin resistance and liver insulin resistance, which in turn lead to the metabolic problems that we call NASH. So all of this in turn will eventually lead to the accumulation and generation of ceramides, oxidative stress, and mitochondrial dysfunction, which leads to beta cell dysfunction and then worsening of insulin resistance and other cardiovascular outcomes. So this in general is what happens in diabetes and also in NASH and NAFLD. So there is a lot of overlap depending upon the ability of the pancreatic beta cells to overcome some of these stresses by able to secrete enough insulin, you may or may not develop diabetes. As you can see, there are more people with Nafld and Nash than there are people with diabetes, and that is because if your pancreatic islet cells are good, then it won't progress. Now, this is not the only factor. So there is a gene-environment nexus that actually at the level of the liver, because what I described there was simply showing you how fat accumulates in the liver. That is fatty liver, but it does not necessarily mean that there is any damage. But the progression of that, is worsened by a number of factors. Of course, one of the things that drive it are obesity, diabetes, alcohol use, metabolic syndrome, all of these. And then there are a number of genetic factors which interplay and lead to progression. Some of them are protective and some of them are harmful. And then there is the role of gut microbiome and bile acids, which play an important role in the progression and evolution of this disease. So there is a very complex set of pathophysiological factors that lead to more advanced disease. And the reason why it is important is because at this point, we do not have a single way by which we can treat this disease. And there are multiple targets when you look at this to see if there are opportunities to intervene. And also there is a tremendous amount of heterogeneity of the disease itself. So that is because there are so many factors involved in the development and progression of this disease that, it's probably due to different factors in different individuals. So the current therapeutic targets, which are based on what I just described, that have been undergoing clinical trials, include things such as drugs that will affect, much of them have an impact on diabetes, and some of them will have an impact on lipid metabolism. So like GLP-1 analogs, insulin itself, then we have the TZDs, which have an impact on insulin resistance. Then you have, drugs such as the Sglt2 inhibitors, which have been developed. And these are a list of drugs that are currently undergoing or have been through several stages of clinical trials. These are for Nafld, and this is for progression from Nafld to Nash. That means the mechanism by which fat accumulates is in itself is different from which there is injury to the liver and progression to cirrhosis. So there are two different sets of drugs that are being developed. So there's been much interest in one particular group of compounds of drugs, which is the GLP-1 analogs. So this paper that was published earlier this year, this is a placebo-controlled trial of subcutaneous semaglutide for NASH. This was published in the New England Journal. And this was a 72-week double-blind phase 2 trial involving biopsy-confirmed NASH and liver fibrosis stage F1, 2, or 3. They were assigned to different doses, 0.1, 0.2, or 0.4 milligrams in corresponding placebo. And that's the thing about this is that this is per day. We are used to using semaglutide per week, because we, currently for diabetes management, we are using 0.5 milligram or 1 milligram weekly doses of semaglutide. So it is actually, this is a daily dose, a daily injection. So if you know, the recently they approved a new formulation of semaglutide called Wegovy, which is 2.4 milligrams. So that's a much higher dose. That is still lower than the 0.4 milligrams daily dose. So this is not the same dosing that we use currently for management of diabetes. So the primary endpoint was the resolution of NASH without worsening of fibrosis. The secondary endpoints was improvement in at least one fibrosis stage with no worsening of NASH. So what you see here, again, with these different doses, this looks at resolution with no worsening of liver fibrosis. And you can see that there is a significant improvement in the resolution of NASH with no worsening of fibrosis. However, when you look at improvement in fibrosis with no worsening of NASH, there is there is some response, but really not as much of an improvement. So, it certainly had an impact on NASH with no worsening of liver fibrosis. So again, you can see here with the different doses, there is this, as expected, you will see a significant drop in the hemoglobin A1C by 1.15% here with the highest dose. And these are the changes in the enhanced liver fibrosis scores and body weight. And this is important in the sense that one of the biggest questions about the mechanism of action is it because they lost weight? Because on their analysis it was not related to weight loss. So because there was a significant amount of weight loss with the highest dose of semaglutide, much more than all these other doses, and you can see improvements that you have with the other components of this disease. So this shows you the changes in the ALT and AST related to over time with the different doses of semaglutide. So when you look at the other drugs in the same category, this was just published, or this is not published yet, but this is published online just this month. That's why it's under a different category. But what you find here is that you don't, you have kind of a trend towards change in the liver fat and scores. However, not all of these trials were specifically addressed to patients with Nafld or Nash. So that's the reason why it's important for us to recognize that this study was different. This was a lot more patients and was also directed towards the particular population where it was concentrated on patients with Nash and Nafld. So we have to see what the longer term outcomes are going to be and what dosing we have to use with the currently available preparation that we have and whether we get similar results. You can see here that we don't have a result that is as with the currently available dosing. Now, the other class of drugs that have been of interest is the Sglt2 inhibitors, which again, these two classes of drugs have gained a lot of attention because of their good cardiovascular outcomes. So they have also been studied in the context of So this is one of the studies, a South Korean study, where again, the Sglt2 inhibitor was more effective in weight reduction and ALT improvement in patients with type 2 diabetes and comorbid Nafld. Again, these are not studies that have done as much of a look at the fibrosis scores and NASH scores itself. So that's why it's important for us to look at studies that have looked at multiple outcomes. So this is the summary of all the different drugs that we have. You can see among these drugs that we have, semaglutide appears to have the most promise that we have so far. Okay. Then you have the DPP-4 inhibitors did not have any effect on liver enzymes or any of the hepatic outcomes. Then you have TZDs. TZDs, pioglitazone has been studied. It has been shown to decrease liver enzymes. But again, there is a decrease in the inflammatory score, but fibrosis-wise, it does not have as much of an impact. With the Sglt2 inhibitors, there are some studies that do show an improvement with dapagliflozin and decrease in liver fat and also in liver stiffness. They do lose weight. They improve blood glucose control, A1C and fasting glucose levels. Empagliflozin, again, there are studies that show decrease in ALT and decrease in liver lipids. And of course, one of the things about these drugs, the Sglt2 inhibitors and GLP-1 analogs is their benefit on cardiac and renal function. So in patients with diabetes, it makes a lot of sense for us to use more of these, although cost and other factors need to be considered. So the other thing that we have to look at is, what about insulin? So this is the reason I bring up this study is because this is one of those which had a very interesting insulin that they used. There is an insulin which is pegylated Lispro, or it's called Lispro, which is called invasive insulin Lispro, and they compared it to insulin glargine. Pegylated Lispro is a longer-acting lysine protein homolog, but it binds to the liver. So it has a specific liver effect, which actually is very helpful in controlling fasting blood sugars. So they had postulated that it will improve decrease hepatic gluconeogenesis and has some benefits. And they compared it with glargine. Well, it does do that. However, one of the things that they found with this is that when you use pegylated Lispro, there's actually an increase in hepatic fat and liver stiffness. So that's the reason why it didn't come to market. It was not pursued further. Although there is an indication that maybe if they had continued to use the drug, there would have been a different outcome, that it would not have caused progressive liver function abnormalities. But it was too risky for them to continue to do studies, so they did not pursue that. But one of the things that we learned from this is the fact that insulin itself does not, the current insulins that we have do not affect liver fat much. They don't either have beneficial or worsening effect, but the pegylated Lispro does have it. And this study was done in both type 1 and type 2. And again, what you find is that type 2 patients have a higher amount of CK18 compared to type 1 diabetics. Now, what about Nafld in patients with type 1 diabetes? So this is a systematic review and meta-analysis because we now know that there is an increasing rate of obesity in patients with type 1 diabetes. So they looked at all the studies that have been done so far in this, and the pooled prevalence of Nafld was 19.3%, and increasing to 22% in adults only. The pooled prevalence of ultrasound studies, again, was high with 27%. If you did magnetic resonance imaging, was 8.6%. Liver biopsy was 19%, and transient elastography 2.3%. So one of the things that you find here is that because different studies have used different methods of evaluating liver fat and Nafld, you have different numbers. But in general, there seems to be a high prevalence of fatty liver in type 1 diabetes, particularly adults with type 1 diabetes. So one of the cautions that we have is that the growing obesity prevalence in type 1 diabetes, that would be something that we have to keep in mind. And then there are a number of patients who we call as double diabetes. That is, people who have type 2 diabetes genotype who also develop type 1 diabetes at a younger age. And over time, they develop features of both type 1 and type 2 diabetes. And then, of course, the thing about type 1 diabetes is the long duration of the disease. So not only are they exposed to higher blood sugar levels, but they will be exposed to higher blood sugar for a much longer period of time. So this is one of the things that is kind of unique to our patients that we see, which is hepatic steatosis after islet transplantation. So we've been doing the islet transplants here since 2015, and sometimes we get reports from or someone calls us and says this patient has all these liver lesions. But one of the things that is well known is that in patients who have islet transplantation, because the islets are deposited in the liver, there is a higher amount of fat that is around these areas of islet deposition. So in this, this is the clinical islet transplant program in Canada, and they had followed these patients over time, and they looked at the patients to see if those who had more fat in the liver had a worsening of their, what happened to the islet graft function. And really, there's not much of a difference. So, which to me was a bit surprising, because I had always thought that if the islet graft doesn't function well, that we're not going to have steatosis. But in their study, even when the islet graft was not having high amount of C-peptide or insulin secretion, there was still imaging evidence of steatosis. So this is one of the more recent studies, and to highlight that the difference here is, instead of having a diffuse distribution of fat, you can have pockets of fat seen in the liver around the sites where the islets are. So you see that 63% of patients had steatosis present on MRI after TPIAT. 48% had an atypical pattern. That means it was not uniformly distributed. So that will raise a lot of concern. People want to do biopsies. They may think that this may be a tumor or anything like that. But the thing is that in patients with islet transplants, you can have atypical pattern of distribution of liver fat. So to summarize this portion of NASH and diabetes, Nafld is associated with a 2 to 3-fold increased risk of developing type 2 diabetes, while patients with Nafld have higher prevalence of steatohepatitis, liver fibrosis, and end-stage liver disease. They're insulin resistant not only at the level of the muscle and liver, but also in the adipose tissue. Dysfunctional adipose tissue and increased rate of lipolysis contribute to ectopic fat accumulation, development of insulin resistance, lipotoxicity, and impaired beta cell function. Excess free fatty acids availability is also an important cause of inflammation, mitochondrial dysfunction, increased oxidative stress, and an uncoupled oxidative phosphorylation, activating fibrogenic response in hepatic stellate cells that promote the progression of NASH and cirrhosis. Glucotoxicity, that alters the intracellular glucose and lipid pathways and promotes cellular dysfunction and eventually death. Glucotoxicity and lipotoxicity are closely interrelated. Both contribute to insulin resistance and impaired insulin secretion. So among the pharmacological agents currently used, TZD, the pioglitazone, GLP-1 analogs, and Sglt2 inhibitors are promising for management, although more work needs to be done. So in the ADA's 2019 guidelines, they recommend universal screening for advanced fibrosis in all patients with prediabetes or type 2 diabetes with cirrhosis, with steatosis and elevated ALT, to identify and treat those with the highest risk of developing advanced fibrosis. So the next thing is that, as I talked to you, the biggest concern in patients with Nafld, and also the biggest concern in patients with diabetes, is cardiovascular disease. And the thing that sets it, kind of links them together, is the metabolic syndrome. In 2009, the ACC and the adult treatment panel, as it was called at that time, they all included metabolic syndrome as a cardiovascular disease risk equivalent. So it really, highlights the importance of metabolic syndrome, which is a result of obesity and adipocyte dysfunction, increased insulin resistance, and leading to this, causing cardiovascular disease. And of course, the metabolic syndrome, all these components, arising from the basic pathophysiology of the metabolic syndrome, leads to Nafld and NASH. And then, of course, it can go on to cirrhosis or other, and hepatocellular carcinoma. And then there's chronic inflammation. And these, of course, are all linked to diabetes. So there is increasing incidence of obesity, metabolic syndrome, and CVD. And of course, NASH is also directly, and is a consequence of all of these things. Whether Nafld itself is independent of all these other factors, is a cardiovascular risk factor, is questionable. There is some evidence that it is, and others who question whether it's a direct effect or an indirect effect, because the milieu in which Nafld and Nash develop are things where there is a high risk of cardiovascular disease. So, you can see here that, you have obesity, insulin resistance, and metabolic syndrome. There are other things that come as a result of liver disease, which includes dyslipidemia, hepatokines and coagulation factor abnormalities, which increase the risk. And whether, if you don't have the metabolic syndrome and you develop Nafld due to some genetic factors that drive this, will that cause also cardiovascular disease is something that needs to be clarified. But it is something that we need to keep in mind. And one of the biggest things that as practicing clinicians we face is seeing a patient with Nash who has high cholesterol. So the question is, are statins detrimental in patients with Nafld? In general, we can say that really no. They have proven hepatosafety in patients with elevated liver transaminases and chronic liver disease. Are they helpful? Certainly, when you look at the evidence that is there, there's no evidence that people with Nafld will not respond to cardiovascular risk reduction with statins. So for that reason, we do recommend that they be used, but with some caution. And some of the things that we need to keep in mind is the different drugs that are available and their interaction with other medications when we address the issue of cardiovascular risk reduction in general and in patients with Nafld. So this is the quadrangle of care for patients with type 2 diabetes. One is addressing the issues with Nafld, of course with cardiovascular disease in general, but directly, then addressing the pancreas and the kidney. And one of the things that I have to highlight is that the one constant is lifestyle modification, which we underrate and don't apply too much attention to. So lifestyle intervention in all of these. But then you have these different drugs, and you can see again statins included in all three of these. Of course, bariatric surgery will help with fatty pancreatic disease. So, that is the approach that we should have in a comprehensive care pattern. So with the endocrinopathies in general, there has been attention now paid because Nafld has been recommended commonly in hypothyroidism, PCOS, hyperparathyroidism, growth hormone deficiency, hypogonadism. And the relationship is a bit more complex. And many of these have features of the metabolic syndrome: obesity, hypertension, dyslipidemia. So is it all just that, or is there an underlying different endocrine mechanism that is at play in these different disorders? So that is something that needs to be evaluated. Some of these disorders are not common, so it's more difficult to study them. So we base it more on mechanistic approaches rather than having to conduct large randomized clinical trials. So with respect to polycystic ovarian disease and Nafld and Nash, of course PCOS is the most common endocrine disorder in women of reproductive age. So, usually diagnosed with the Rotterdam criteria. And there are both, environmental genetic factors that are involved, and several genes involved in type 2 diabetes and insulin resistance occur in about half the women with PCOS. So there is evidence that women with PCOS have insulin resistance. So in a meta-analysis of 17 studies, there is significantly higher risk of Nafld in women with PCOS than in controls. So it's about 2.25. And this was independent of obesity and geographic region, but might be correlated with hyperandrogenism. In another retrospective longitudinal cohort study using a large database, found that women with PCOS had an increased rate of Nafld, also adjusted for BMI and dysglycemia. So the prevalence of Nafld in women with PCOS varies between 35 and 70%, depending on the diagnostic method used for both PCOS diagnosis and Nafld diagnosis. So the question is it an independent risk factor or not? That is something more difficult to delineate. So this was a study that was published last year, and it is interesting in that it is actually an inpatient sample. So, and they did this because there was this huge amount of data available on liver tests. So in this particular study, they looked at the National Inpatient Sample Database between 2002 and 2014. The number of patients is very high, 50 million people. 77,415 had PCOS, and these patients were younger and more likely to be obese compared to the non-PCOS patients. However, the PCOS group had less hypertension, dyslipidemia, and diabetes. And when they used multivariate logistic regression, patients with PCOS had significantly higher rate of Nafld. It's 4.3. So it is very high, actually. So when you look at this figure, you see this is the univariate analysis where the risk is at 7.86, and with multivariate analysis you have 4.3. When they looked at the multiple regression analysis of association of PCOS and Nafld, you'll find that it is one of the highest that you have, more than that for obesity or hypertension or dyslipidemia or any of these others. So you find that the association between PCOS and Nafld, of course, this is a sample that was skewed towards people who were sicker because they were in the hospital for one reason or other, most of them for surgical reasons. And so that's one of the reasons why this is skewed, but it still gives us an idea that in patients who have PCOS, there's a higher possibility of having Nafld. So the other thing in this population that one should be careful about is that common treatments for PCOS may have some impact on liver enzymes, like clomiphene, could affect the liver enzymes, even in the setting of mild abnormal liver functions. Aromatase inhibitors, insulin sensitizers, of course, both metformin and TZDs will reduce it. Oral contraceptives, might deteriorate the severity of Nafld due to its adverse effect on lipid metabolism. But in a population study, they did not find a relationship, and in fact, people who are using the oral contraceptives, there was a reduced risk of Nafld. Then use of anti-androgens. Spironolactone has been shown to be actually beneficial. And then, of course, lipid-lowering drugs, might have some impact, both positive and negative, in patients who have PCOS. Now, this is a very interesting study published earlier this year, and this used a combination of 3 drugs, spironolactone, pioglitazone, and metformin for treatment of young adolescent women with PCOS, and compared it to just oral contraceptive. And they looked at the hepatic fat content, and you can see here there's a significant reduction here compared to a slight increase that you see with in the hepatic fat with OCPs, a decrease in the home IR as you expect. So the dose here on the spironolactone is 25 milligrams. The pioglitazone dose is very low. It's only 7.5 milligrams, and the metformin was 500 milligrams. So it's kind of a low dose of 3 different drugs that we use. We don't use much of pioglitazone for PCOS, but in this population they were lean. So the study, when they stopped the treatment and they looked at ovulation rates, they actually had a higher ovulation rate with this combination medication. So this kind of interesting, looking at some of the mechanisms by which PCOS might be affecting fatty liver. So the practice points here is that Nafld and Nash are common hepatic manifestations in women with PCOS, may not only be present in obese and overweight, but also in lean women. They should be screened for Nafld and abnormal liver enzymes. Women with PCOS are prone to have a more advanced status of Nafl due to insulin resistance. And of course, a number of things that are still out there is to develop better markers, looking at the medications that have beneficial effects on these individuals. Hypothyroidism and Nafl or Nash, there are conflicting results, and most of them obviously are observational studies. So with meta-analysis, there have been divergent findings. This may be due to criteria that have been used. Collectively, what we can say is that a significant and independent association between subclinical and overt hypothyroidism and the risk of Nafl needs to be conclusively proven. So there is some indication that probably there is a higher rate of Nafl. Again, because people who are overtly hypothyroid tend to be overweight or obese, it would not be surprising that they may have more hepatic fat. So these are the different studies that have been coded in these works. But the thing that I wanted to talk to you about is that the thyroid hormone has different effects. It has the ability to decrease some of the aspects of liver metabolism, decrease clearance of insulin. Hypothyroidism, you can have impairment of lipid metabolism, expansion of visceral fat, chronic inflammation, and a steatogenic effect because of low levels of thyroid hormone. So the interest in this was particularly highlighted by the fact that there are now some drugs that have an impact on fatty liver, which are thyroid hormone related. So as you all know, thyroid hormone works through a nuclear receptor. It binds to its receptor, which then is a heterodimer with RXR. So this then will bind to the thyroid hormone response element in different genes. So either activation or repression of these genes. So that is the basic mechanism by which thyroid hormone acts. And there are different isoforms. There is TR alpha. TR alpha 2 is not really an active form. It does not bind to T3. And then you have TR beta 1 and beta 2. So there are different isoforms of the thyroid hormone receptor which are differentially distributed. And the particularly of interest is the fact that the beta isoform is expressed in the liver, whereas the alpha isoform is in the heart. So one of the biggest problems when we try to use thyroid hormone is that you will have cardiac side effects, tachycardia, and irregular heartbeat. So for that reason, if you use a TR beta agonist, it is possible theoretically to have a liver effect without having a cardiac side effect. So there have been different things that have been tried. They tried T3 itself, but it has too many deleterious effects, so they haven't used it. There are a number of thyroid hormone beta selective agonists that have undergone trials at various stages. Although there are some results that indicate decrease in steatosis, nothing really that we can get an approval for in terms of good outcomes. There are still ongoing trials with different TH or beta selective agonists. Then there is now an interest in some of the thyroid hormone metabolites, both T2 and T1AM, which were thought to be totally inactive, but there is evidence now that they may have some beneficial effects, and also some adverse effects. So those are being studied. And of course, male hypogonadism. Studies in males have reported an association between low testosterone and increased visceral adipose tissue, insulin resistance, and dyslipidemia. The association has been observed in several epidemiologic studies, and in meta-analysis of 16 studies has confirmed the association between lower testosterone levels and Nafl in men. Preliminary evidence suggests that men rendered hypogonadal by androgen deprivation therapy for prostate cancer have a higher risk of progressive Nafl. So, we know that testosterone plays a role in insulin sensitivity, body composition, lipid metabolism. A bidirectional relationship exists between low levels of testosterone and insulin resistance. In the heritage study indicated that people with low testosterone have a preferential accumulation of abdominal fat and higher visceral adipose tissue accumulation. Low levels of testosterone and SHBG in men are independent predictors of occurrence of metabolic syndrome, and I'll come to that a bit in a bit. And low levels of SHBG associated with increased risk of developing metabolic syndrome, gestational diabetes, type 2 diabetes, and is often studied as an early biomarker of these disorders. So, obese insulin-resistant patients with low SHBG often have fatty liver disease. So there is this link between testosterone, SHBG, insulin resistance, and of course fatty liver. So one of the things, now I have two studies. I know Dr. Winters is thing, and he is watching, and he will be able to comment on this better. But I found these very interesting. Two publications of his. One was very recent, looking at the hepatic lipidome and HNF4 SHBG expression in the human liver, and relevant to our topic today, looking at the relationship between SHBG and hyperinsulinemia and hepatic steatosis. When they looked at this, both steatosis and high insulin resistance were associated with high levels of saturated and unsaturated fatty acids other than arachidonic acid. And what they also found that individuals with low HOMA-IR had low levels of total hepatic fatty acids, while both low and high fatty acid levels characterized high HOMA-IR group. Both insulin resistance and high levels of hepatic fat were associated with low expression of HNF4 alpha and thereby SHBG. Expression of these genes were also low in the absence of these, implying other factors that may be playing a role. So the relationship of all fatty acids studied to HNF alpha and SHBG was inverse and similar to that of total triglyceride concentrations, irrespective of chain length. So the reason I brought this up is because there is a considerable interest in developing markers for identifying people at high risk and looking at progression of the disease. And one of the things is SHBG, which has been proposed as a marker for progression from prediabetes to diabetes, may also play a similar role here. And another study, they looked at a similar thing, this again in liver biopsies, and I just highlighted that SHBG mRNA as well as serum SHBG were higher when hepatic triglyceride concentration was low, and decreased with body mass index, but were unrelated to age. Fat accumulation in liver and insulin resistance are important determinants of SHBG expression, perhaps mediated through through HNF4 alpha. So when we look at many of these studies in which have looked at testosterone, they do not take SHBG into account, and that has been one of the things that has been a major problem in trying to understand these studies. So this is a very recent study that was published last year, looking at oral testosterone and its effect on liver fat in patients who are hypogonadal. So this one is LPCN 1144 liver fat study. So this is part of a larger study looking at this particular oral testosterone preparation. It is oral bioavailable bioidentical endogenous testosterone. It was given twice a day, 225 milligram TU 30 minutes after a meal. They wanted to assess changes in hepatic fat content measured by MRI proton density fat fraction from baseline to 8 weeks and at 16 weeks. And in this population, 21 individuals had greater than or equal to 5% hepatic steatosis. That means of the 32, 66% had hepatic steatosis. So that tells you that hypogonadal men have higher rates of hepatic steatosis. And the mean was high at 12.1%. 25% had hepatic fat greater than 10%. Again, telling us that in individuals with low testosterone, there was high hepatic fat. So when they upped the treatment, 63% of the study population had less than 5% fat, as measured by this, and 91% had less than 10%. So Nafld resolved in 33% of subjects at 8 weeks and 48% at 16 weeks. So this is a phase 2 small study. There are only 32 patients that they studied, but this early exploratory thing showed that in hypogonadal males, this oral testosterone preparation reduced steatosis and with higher degree of baseline, particularly with those with higher degree of baseline hepatic fat content. Growth hormone deficiency again has been linked to development of fatty liver. So particularly in patients who are hypopit, more severe growth hormone deficiency is associated with advanced fatty liver. So this is one of the studies that was published in 2007. This is a single patient. You can see the effect of growth hormone treatment in this individual. So you see the baseline IGF-1 at 16.5, 147 on treatment, and they escalated the dose from 0.2 to 0.4 to 0.8 milligrams per day, and there is a steady decline in the ALT, AST, and GTP, HSCRP, and TNF. So all these improved, and so did the histology. So this is a single case, but it is quite dramatic that this patient had such a marked improvement in the hepatic parameters that were studied. The long-term effect, this is a larger study that actually looked at 31 patients who received growth hormone treatment for more than 24 months, compared with 19 age and sex-matched people who had growth hormone deficiency but did not receive any growth hormone replacement therapy. And they looked at the long-term effect on 14 patients diagnosed with Nash by liver biopsy, among these things. And they subdivided the group into GH responders and non-responders. And they found that in this particular study, there was a significant reduction in liver enzymes and fibrosis markers in patients receiving growth hormone replacement therapy compared to the control group. In addition, the growth hormone replacement therapy also improved liver enzymes levels in adult growth hormone deficient patients with NASH. The GH non-responder group showed a higher proportion of patients who gained weight during the study period. So these results indicate that growth hormone replacement is efficacious in improving liver enzymes for at least 24 months in patients with adult growth hormone deficiency. So now, the last thing I wanted to talk to you was just to give you a brief outline about lipodystrophy syndromes, which are metabolic problems, which they are rare, but they have the congenital lipodystrophies, both the congenital complete lipodystrophy and partial lipodystrophy. Then you have the acquired lipodystrophy syndromes, different types of adult syndromes that we have. And the main difference is that the difference between what happens in the lipodystrophy syndromes and what happens in obesity is in lipodystrophy, you have less fat. There is a decrease in leptin and a decrease in adiponectin, whereas in obesity, you have a high leptin and low adiponectin. These people have very high triglycerides and are insulin resistant, much more than the average person with obesity. And so interestingly, there is a subgroup of patients who are obese who also have low levels of leptin. And so this just gives you a general outline of what happens. There's a metabolic component. Interestingly, in this group of patients, especially the certain viral disease and HIV and heart also lead to development of lipodystrophies. And in these, the basic treatments that we apply, in the case of the lipodystrophy syndromes, in the complete generalized lipodystrophy is leptin, because they're severely leptin deficient. If you give them leptin, it will improve their insulin resistance and liver fat dramatically. In the the acquired generalized lipodystrophy, leptin deficiency state may not be as severe as in patients with the congenital forms. You can also treat them with antidiabetic drugs, and if they have some autoimmune disorders which tend to be associated, you can have you have to use corticosteroids. But leptin will work. In the partial lipodystrophy syndromes, TZDs will work in improving their insulin sensitivity and improving their blood sugars and hepatic fat. And of course, leptin has also been used. In the HIV-related group, there's not much of a benefit by using leptin. So there are some other studies that are looking at the use of leptin in the obese individuals who do not have enough, who have low levels of leptin. That's a subgroup of patients. So the reason I said I'll talk to you about this particular month was because this month there was this editorial that was published in 4 different journals: Gastroenterology, Obesity, Diabetes Care, and Metabolism, saying preparing for the NASH epidemic, a call to action. And this basically lays out the field that Nafld and NASH are common conditions with a rising burden. There are significant management gaps between clinical guidelines and practice. There's no single global guiding strategy for the management of Nafld and NASH. So the AGA, in collaboration with 7 professional associations, they convened this meeting to come up with some plans. They reviewed and discussed the published literature on the global burden. Participants identified promising approaches to clinical practice and prepared comprehensive unified strategy for primary care providers and relevant specialists encompassing full spectrum of Nafld NASH care. They also identified specific high-yield targets of clinical research, and their recommendation was developing more sensitive and specific diagnostic markers, adopting a multidisciplinary approach to NASH, which is one of our goals here, which includes primary care, hepatology, obesity, endocrinology, and then developing clinical care pathways that will help guide the clinical care in an efficient manner, and then pursue a unified international and public health response. So, this was just published this month in these journals, and coincidentally, we decided to have 3 talks on Nafld and NASH this month. So I want to thank some of the people that helped me over the years. Carlo Tamburo, who first introduced me to the concept of NASH. And when I looked at this timeline that was published last year in Gastroenterology about NASH, so it was somewhere here in '94, I think, that I was interested in it. And there was very little papers. And Nafld publications, you can see that there was just a blip in those days. And we had this thing looking at the metabolic features and also, looking at insulin resistance. Alan Paris was an endocrinologist who was here. He, with Ahmed Kiseva, was the first to describe the relationship between insulin resistance and visceral fat using clamp studies. And he taught me how to do clamp studies and study some of these things. Of course, Dr. McLean and Barway from Liver have been very helpful in helping me understand the topic of NASH. And Dr. Steve Winsers, all these years, very supportive, and also his own work, which kind of overlaps with some of these things, and very deep insight into science in general helped me keep my interest in this. So I will end here and we'll be happy to answer questions.
Hi, Dr. Mokshagundam. Hello, can you hear me? So, this is Swapna. It was an excellent talk, just much needed and very, very comprehensive. I do have a very basic question. I don't think I either missed it or didn't understand. How do you distinguish between NASH and Nafld clinically? even with ultrasound or FibroScan.
Swapna, I can't hear for whatever reason. I don't know. It's a problem with.
Oh, can you hear me better now?
Yeah.
Is this better?
No, I don't know if it's a problem there or a problem here.
Maybe one of the others.
I'm not sure how to handle that. Let's see. Let me get rid of the video.
Yes, we can hear, but it's very.
She can put the question in the.
Yeah.
She said it's excellent talk.
Yeah, Lisa says that she can hear her, but for whatever reason, I can't hear.
Maybe the setup.
Okay, can you hear me now?
Well, the basic, the final distinction between Nash and Nash is physiological, and there are other markers that are used to distinguish. And I think that would be an area that will be covered next week quite professionally by Dr. Jobson. So I will leave it there.
Oh, okay. Okay, thank you.
Yeah.
I have a question since.
Yeah. Dr. Johnson, did you say something?
Yes, I can most certainly cover that next week, but I would say that when I have patients who are sent to my clinic with some kind of evidence of having hepatic steatosis, be it found incidentally on ultrasound or having a liver biopsy that shows steatosis or having a FibroScan with a cap that is consistent with significant clinical steatosis, how do you distinguish if this is Nash versus bland Nafld, which has no accompanying inflammation? So the gold standard for that is a liver biopsy and seeing an inflammatory component to the disease. I think that Dr. Mokshagundam had shown a slide showing that you can have fibrosis in a certain group of individuals who have technically normal ALT. So I would say that our range of ALT that's used by different labs where they have their reference range is probably higher, the reference range, the upper limit of normal than I would say is normal. So I'd say anything an ALT over 30 I consider to be abnormal. And then in individuals who actually have NASH, they can have undulating transaminases so that you may check their transaminases at the time that you're working up and they're stone cold normal. And so you may say, okay, this person doesn't have evidence of NASH, maybe they just have bland steatosis. But then 3 months down the line or 6 months down the line, they may have a transaminitis that's 2-3-fold the upper limit of normal, and it does undulate. So the bottom line is that the gold standard is still a liver biopsy.
Thank you.
Dr. Mokshagundam, I do have a question. When you're looking at hypogonadism, particularly for people who would like to have a testosterone supplementation, you had some excellent data on the oral formulation. What are your thoughts about the dermal formulations versus injections and how it could potentially impact steatosis?
Well, can you type that question? Because I can hear it, but not fully, you know? Uh, So the data on those, you know, there are studies that show that there is an improvement in liver enzymes, but really not specifically looking at the way that currently you would accept it as a valuable thing for Nafld or Nash. You know, looking at either fibroscans or MRI-PDFFs or other liver markers. You know? So there are no recent studies. I mean, there are studies that use those kinds of markers to show that. You know, but again, in many of these other studies, you know, testosterone replacement can have changes in body composition, and whether you can just explain it on the basis of change in body composition, or was it a specific effect of testosterone replacement? You know, that is something that is more difficult. And since these studies are not directed specifically to looking at the liver, the data is just not there. I don't know if Dr. Winters can comment on that.
Well, I don't. Can you hear me? I'm not sure if everything's working right. Can you hear me?
We can barely hear you. Yes, but others can hear you. You can. I can't hear. That's the problem.
Okay. I don't hear it that well. But anyway, so thanks for recognizing our work that some of our fellows contributed to. And of course, I've been interested in this for a long time. And it's a very complicated story, just like the rest of what you discussed. It's very complicated. And I think you're right. I mean, some testosterone replacement studies have shown beneficial effects on body fat, some on subcutaneous fat, some on insulin, visceral fat. There probably is an improvement in insulin resistance. I think most of the studies show that. And it's also a matter then of dosing. You know, you have to give a lot to try to get these beneficial effects. So you may then be getting into some side effects, prostate growth, other things that people worry about. So they try to tailoring some specific type of androgens, which might do something unique, as you discussed, you know, might be okay. And I just want to point out that this HNF4 is really a very, from my reading, and I should have reviewed my own paper before your talk, but it's really a very key element in all that. It controls half of the genes in the liver, and if you render a mouse deficient in it, they develop a lot of metabolic abnormalities. So that I think there's a lot of basic science research to show how HNF4 might be a key player. And one of the genes regulated by HNF4 is SHBG. So the HNF4 goes down with too much insulin. It suppresses the promoter. And cytokines suppress the promoter. So that's why you get less HNF4 in the setting of the fatty liver. And one of the consequences of that is low SHBG and thereby low testosterone. So many of the men aren't really testosterone deficient. They're just SHBG deficient. And that's another big controversy in the field. Maybe I'll stop there.
So there's one other question here which I will answer, which Dr. Philip may ask, about sarcopenia and NASH and physical exercise. Certainly there is a lot of data on that. There is an interesting set of data looking at the muscle-liver crosstalk, how exercise can improve NASH, and also in spinal cord injury, where physical therapy and increasing muscle mass could actually improve NASH. So I didn't bring that up because of lack of time, but certainly sarcopenia and particularly sarcopenic obesity are associated with Nafld and Nash. Okay, thank you all. It's time. We started late and ended a bit later, so thank you all for joining. Next week, Dr. Joplin will be talking on a slight variation of this topic. Okay, thank you.
Okay.